Good morning, everybody. Today I'm presenting the maternity care model, which I'm proposing to be used during national disaster setting in rural Sindh, Pakistan. Now, Pakistan is amongst one of the few countries which are at increased risk of annual natural disasters. In last 10 years, Pakistan faced 2 earthquakes, 4 years of flooding, and 2 large internal displacement events. Rural areas are the ones which are mostly affected by such events, and unfortunately, these areas are the similar which have high maternal mortality rates. Now, what happens that community health workers are the primary health care providers in such areas, and there are some 125,000 community health workers in Pakistan, such as lady health workers, community midwives, family welfare worker, and lady health visitors. Now, we rationalize this study that these community health workers can be used as frontline maternity care providers because they are local, trained, experienced, and most of them are regular government employees. For those who work on community level, they have direct working relationship with district health facilities. So my research question is, what maternity care model can be used or developed which uses the existing health workers to improve the maternity care during natural disaster or humanitarian emergency setting? For that, I conducted interviews with women, community health workers, key informant. I conducted a survey with women who gave birth in last 5 years, and half of these women were pregnant during floods. I also conducted a workshop with 10 health workers. So amongst my key findings, first of all, I would like to tell you that Pakistan has a very well-structured decentralized district management system in which the active role being played by the district management. However, in my findings, it is said that district authorities were not able to deal with the mega disaster because of their lack of preparedness and limited capacity to deal with such events. In terms of health, the district did not have emergency health funds, neither they have a practical plan to execute. In the absence of that, the human resources and the financial resources were not optimally utilized. The role of health cluster and international organizations were not clear, and there was no obvious connection between district authorities and such organizations. Those women who gave birth in relief camps said that there was only a health camp which provided medicine for general ailment, and there was no obstetric services or maternity services available there. There was weak referral system, so laboring women were not providing transportation facility to go to the nearest health facility to give birth. Consequently, women gave birth in open spaces with other women who provide screen for privacy. 61% of the births were attended by traditional birth attendant due to the unavailability of skilled birth attendant. And there is no breastfeeding station. Babies who were born during floods did not receive neonatal vaccination, and contraceptions were not available there as well. So here is the model, which has 3 stages: preparedness, early warning, and evacuation. At the preparedness stage, I recommend training of all community health workers as humanitarian workers. The district health officials should be trained on disaster management and mitigation strategies. All the facility staffs should be EMOC trained. There is an immense need to do the need assessment at the preparedness stage, so that we should know how many pregnant women do each district expect to be looked after. Networking again is also very important. The district health manager should be able to identify what kind of organizations work in that district or nearby district, and with the help of a good need assessment, the organizations who are identified can be informed about the potential essential MNCH supplies which are required at the time of any national disaster. At the early warning stage, the lady health workers should inform all pregnant women about the relocation and mitigation strategies. The district health department should have a record of all pregnant women who are expected to deliver in that month so that they can be safely relocated. And of course, on the basis of the numbers, the resources such as clean delivery kit, dignity kit, reproductive health kits, vaccination, and essential MNCH supplies can be sought out. At the response stage, we should ensure that each relief site must have a birthing station and breastfeeding station. The community midwives can be used as skilled birth attendant, and lady health workers can provide the essential vaccination for babies and pregnant women. Contraceptions must be ensured at all birthing site. Referral systems should be strengthened, and women with complicated pregnancies can be transported to the nearest health facility where NMOC trained staff can look after the need of that pregnant woman. On the basis of the size of relief camp, women-friendly centers can also be established, which can provide psychological counseling for women who are victims of sexual and domestic violence. Thank you very much.